Good morning and welcome to this morning's seminar. I am Cecilia Zalkin. I'm President and CEO of Advocates for Children of New Jersey. ACNJ is a state-based child advocacy organization located in Newark. And we are the facilitators of the Think Babies Coalition and the New Jersey Pritzker Children's Initiative, which is an initiative focused on improving outcomes and services to children birth to 3, prenatal to 3, and their families. Maternal and infant health is one of the 4 pillars of our campaign, and we are so excited to be working with NAACP and the people you will meet on this webinar this morning to advance maternal and infant health. Very pleased to host this webinar as part of Black Maternal Health Awareness Week. And I want to start by thanking the 2 co-chairs of our Maternal Infant Health Committee of our Think Babies Coalition, Patricia Canning from ACNJ and Natasha Dravid from the Camden Coalition, for their help and their leadership in pulling together this workshop this morning. This morning's webinar will feature the Maternal Health Experience Survey, which is an initiative in partnership with the NAACP in Atlantic City, the Prematurity Prevention Initiative, and the Family Health Initiative. This is a survey that focuses on understanding the experiences of Black and Brown mothers in New Jersey with the goal of improving maternal and infant health care and reducing racial inequities. The survey has been launched in Atlantic City and will now be used in other counties throughout the state. This morning will be an opportunity to hear about this initiative from the community leaders who have led it, that include healthcare, state and local officials, and many stakeholders in the maternal and infant health field. And they'll talk about how they partnered to launch this survey and the plans ahead for bringing the survey to the rest of the state. This survey and much of the other work that is being highlighted this week in Black Maternal Awareness Week has been led or initiated by our First Lady, Tammy Murphy, who has been an incredible champion for maternal health in New Jersey since Governor Murphy assumed office in 2018. Her leadership has led to NAACP, which was released earlier this year and is an ambitious plan to address longstanding inequities in maternal morbidity and infant mortality, particularly in communities of color. And I think it is her personal commitment that has led to the progress New Jersey has made over the last 3 years and has put us, I think, in the forefront of the country on these issues. So I'm very excited to introduce the First Lady and then turn it over to Patricia Canning from the ACNJ staff to launch the rest of the webinar. Mrs. Murphy, over to you.
Good morning, everyone. Seal, I am so grateful for that introduction and for all of your support and work advocating on behalf of New Jersey's mothers and babies. I count Advocates for Children of New Jersey and Family Health Initiatives as true partners to NAACP in our work to solve our state's Black maternal health crisis, and it is truly an honor to be a part of today's program. This week, Black Maternal Health Week, is a critical opportunity for us to raise awareness of this issue, and importantly, to amplify the voices of Black mothers and maternal advocates across our state. This work is both urgent and necessary. In New Jersey, a Black mother is 7 times more likely than a white mother to die from pregnancy-related complications. And a Black baby is over 3 times more likely than a white baby to die before his or her first birthday. This disturbing reality is a result of nothing other than institutional inequity and racism, and requires sweeping change to a system that has long failed our women and babies of color. For this reason, we have been hard at work for the past 3 years to figure out how we can transform New Jersey into the safest and most equitable place to deliver and raise a baby. To this end, we brought together experts from across the state and country to develop NAACP's statewide strategic plan, a plan designed to completely reinvent the way we care for pregnant women, particularly women of color. And I'm proud to share that many of today's speakers worked with our experts to ensure that the plan was actionable and implementable. So thank you all. The plan is necessarily broad in its scope, but keeps at its center the specific needs of women of childbearing age, right in the places where they live, work, worship, play, and love. The plan increases prenatal care and support for women of color, creates a maternal health research and innovation center, and it makes broad reforms aimed at dismantling the structures that for generations have prevented women of color from living in environments that provide the opportunity to simply be healthy. We've already begun implementation of this plan through the governor's proposed fiscal year 2022 budget across a number of initiatives. First, it includes funding to extend Medicaid coverage for pregnant women for a full 365 days, a necessary bridge that will keep mothers connected to their care team until the federal extension goes live. Second, it contains funding for the Reproductive Health Care Fund, which will ensure that our undocumented mothers are being provided prenatal care, delivery services, and contraceptive care. Third, we are adding funds to create a pilot program within the state rental assistance program for housing support and unique wraparound services for eligible New Jersey pregnant women. And finally, the budget also earmarks funding for a landscape analysis of our birthing workforce and infrastructure, as well as services to combat the primary social determinants of health, and funding for a doula registry so we can continue to support, develop, and sustain our growing doula workforce. The changes we have made and will make in the future reflect an ongoing pattern we've seen over and over again across our state this past year. From our youngest residents to our federal, state, and local governments, to our business community and more, New Jerseyans want to take care of one another. And there is no doubt that this issue is also a part of the national reckoning on racism that we have finally been facing together as a nation. In New Jersey, we are ready to make real change that do more than make small improvements here and there. We are seeking not just equality, but equity. And as we work to implement the recommendations of the plan, we will be doing so together with a wide spectrum of partners. So I really have to thank so many people and organizations for their commitment to seeing this all the way through to execution. Experts, activists, philanthropists, business leaders, and of course, our brave mothers who have spoken up. And today's event and the work done to launch the Maternal Experience Survey are perfect examples of the kind of collaboration it will take to truly solve this crisis. Seeing the long list of organizations partnered here today, ACNJ, Family Health Initiatives, Southern New Jersey Perinatal Cooperative, the NAACPs of Atlantic City and Newark, Sister to Sister Doula Program, Ascenda Health, and Camden Coalition. Working together to raise awareness on this issue reinforces my belief that we are ready to come together to solve this crisis. This issue hits home for everyone. And because solving this crisis requires such sweeping change, there is a role for everyone in its implementation. I am thrilled that the Maternal Experience Survey is focused on amplifying the experiences of Black and Brown women and making sure those who have an impact on their pregnancy experience hear these stories loudly and clearly. This thoughtful, place-based approach to ensure Atlantic County moms are heard and is fantastic, and I'm thrilled that Essex County is next in line. Black Maternal Health Week is about amplifying voices, and it is only through listening closely and lifting up stories and experiences through your own families, networks, and communities that we can begin to make the transformational change needed to truly solve this crisis. After 3 years of work, we see the stars beginning to align. And with your help and the commitment of so many others across the state, I know that together we will make New Jersey the safest and most equitable place in the nation to raise and deliver a baby. Thank you so much.
Thank you, First Lady Tammy Murphy, for being here this morning, and more importantly, for your commitment to Black maternal health in the state of New Jersey. It is certainly felt throughout, and as you've seen, you've been able to gather so many partners to work on this issue. Today, we continue to work on that issue. In this forum, we are bringing to you the Maternal Experience Survey from the people who've created it. You'll hear from them today. You'll hear why it's important from Cheryl Hackett, who is a project director at PPI. You will hear from the people, from the leaders who were present and who made it happen for Atlantic City, such as Councilman Shabazz. And you will also hear from the team that was gathered to make this important survey happen. And I'll be back and forth introducing them, but I just wanted to thank you all for being here today. Please put all of your questions in the Q&A, and we will definitely have time at the end of this presentation to address some of those questions. Now I'd like to bring you to Cheryl Hackett, who is the project director of PPI. She has spearheaded this effort along with some of the other people who you will meet today, Constance Day Chapman, Melissa Fox, and others. Please join us in hearing from her perspective why the historical, oh, she's telling me that Kaleem is going first, of course, okay. Sorry, Councilman Kaleem, you will go on first. We'd love to hear from you, and then we'll move it over to Cheryl. Thank you.
Thank you very much, Patricia Canning. Good morning to everyone, to First Lady Tammy Murphy, Patricia Canning, Nastasia, and all who are listening, our moderator, and Celia. I thank you. I am honored to be on this presentation. Today is, in my mind, a seminal day in our effort to bring equity to the maternal experience of Black and brown mothers in Atlantic City. I'm sorry, not in Atlantic City, in the state of New Jersey. I'm focused on Atlantic City because I also have the great honor to be the president of the Atlantic City chapter of the NAACP, and we have been involved with this initiative for quite some time. Today, I believe that it's important that we are united and focused on the serious fight for our future, the future of New Jersey. This nation is diverse, this state is diverse, multicultural, Black and brown, white and yellow, and every mixture conceivable. Our righteous struggle to ensure that there is equity in treatment, in access, and opportunity for our mothers is paramount to our future success. The pandemic has shown us many things. One clear lesson is that the disparities in medicine and healthcare, insurance access, and healthcare availability has a real cost in human lives. We all know that disparities caused and perpetrated by racism existed before now. But now we see very clearly and painfully the cost. This initiative is a needed step in collecting information, experiences that will help address disparities and close them. In addition, this initiative, as the First Lady indicated, will give those who are in a position to make change the ammunition that they need to make the change that is necessary. Those of us in civil rights and social justice leadership understand clearly that there is no critical, valid discussion of social justice without underscoring, highlighting, and lifting up the issue of Black maternal health. Our charge and challenge is to make this a frontier priority issue. When civil rights and social justice issues are discussed, this concern must be at the forefront. That's why I am so very proud of the work that the NAACP branch in Atlantic City has initiated. with the formation of our Infant and Maternal Mortality Task Force. The task force has been diligent, focused, and productive, and the survey is evidence of some of their commitment. I salute and thank all of the task force members, but I issue a special thanks to our task force chairperson, Mandy Chapman, who has had a serious leadership effort in keeping this task force together and making it successful. And also our maternal health champion, my sister Cheryl Hackett, for all of her hard work. The fight to increase maternal health care can't be won without allies. And if we were to write a description of an effective, proactive ally for this initiative, that description would have to list First Lady Tammy Murphy. She has been the perfect ally, but more than that, she's been an advocate. And more than that, she's been a champion. And more than that, she's been a person of privilege. This initiative is critical, is necessary, is needed, and is timely. So I say very sincerely, let's stay together, let's stay focused, let's continue to make progress, and let's make New Jersey a place where every mother can make sure that her child will have the absolute opportunity to be born in safety and equity and care without disparities or racism or barriers to her health and the child's health. That's in the interest of all of us. Thank you very much.
Thank you, Councilman. We appreciate those words. You for just a little bit, but I think we got the gist of what you were saying. Next, I'd like to introduce you all to Cheryl Hackett, who is the Project Director for Prematurity Prevention Initiative. She will give us a historical perspective on Black maternal health in New Jersey and in the US. And then we will have doula Tatiana Smith talk about her experience and how she supports mothers in the state of New Jersey. Thank you.
Thank you, Patricia. I like to thank the First Lady for all of her work that she has done, and the ACNJ for working in collaboration with the First Lady's office and FHI to pull this event together. We think is vitally important. But we believe that in order to have an understanding of the Black Maternal Experience Survey and why we thought it was important, we think it is important that you understand the historical context of Black women's experience in this country. And we believe once you understand this historical context, the experience of Black women, you will say, how can I support the Black Maternal Experience Survey? History of injustice to women of color in the US is long-standing. Black women's reproduction in the US started with the duality of two contradictory identities, one as a childbearer and the other one as a laborer. Consider this duality and its connection to physicians' involvement. The transport of women on the transatlantic ships occurred under the watchful eyes of physicians that were hired to ensure the cargo or slaves were provided care if they needed it. The cargo, once in the US, was then examined by physicians at the docks prior to being paraded on the auction blocks. The physicians placed market value on their bodies by issuing a certificate of soundness to assure the buyers or sellers of the quality of their purchase or sale. In 1858, an article written by Savannah Medical College professor Jariah Harris declared, "The ability to accurately determine the market value of Black bodies is one of the key professional competencies needed by Southern doctors." Insurance companies would approve a policy on Black bodies only after doctors examined the men and the women. They wanted to make sure they were protecting the financial well-being of the slave owners. Now, let's look at Black women as childbearers. In 1662 in colonial Virginia, a law was passed that legalized, or should I say mandated, that slave status was legally inherited based on the race of the mother. Therefore, only a white woman could give birth to a free child, and only a Black woman could give birth to a slave child. When the slave trade was banned in 1807 to 1808, slave owners could no longer source their slaves from the continent of Africa, so that they shifted their focus to the fertility of enslaved women. Black midwives and nurses provided most of the care on the plantation, except when there was an issue, such as a difficult birth in which forceps were used, and the determination of the slave woman's infertility or investigation of an infant's death was needed. Dr. Francois Marie Prevost pioneered the cesarean section surgery by experimenting on enslaved women bodies without their permission. A name we all may be familiar with is Dr. James Marion Sims, who created the surgical technique for repairing obstetrical fistula by experimenting on enslaved women in Alabama. We must talk about birth control as a lens of which Black women's maternal experience in the US was experienced. Margaret Sanger coined the phrase birth control and spent her life championing women's right to practice contraception. She founded the American Birth Control League in 1921, which joined with other groups in 1939 to form the Birth Control Federation of America, eventually becoming America's leading reproductive rights organization, Planned Parenthood Federation of America. Originally, her defense of birth control was vehemently feminist, as her advocacy centered on the emancipation of women. She was a public health nurse in New York and had witnessed many women with unwanted pregnancies endangering themselves by self-induced abortions. She wanted women to have the freedom and equal participation in society by providing them access to birth control, which would allow women to freely express their sexuality without fear of pregnancy. She famously stated, "No woman can call herself free who does not own and control her own body. No woman can call herself free until she can choose consciously whether she will or will not be a mother." Happening at the same time as Sanger's crusade for birth control was the eugenics movement in America. America had embraced the theory that intelligence and other personality traits are genetically determined and therefore inherited. This belief, coupled with the reform approach of the progressive era, fueled a campaign to remedy America's social problems by stemming biological degeneracy. Why talk about eugenics to understand Black maternal health in the US? Because eugenics shaped our understanding of reproduction and many policies that regulated Black women's childbearing. Many states across the country forcibly sterilized thousands of citizens thought to be genetically inferior. Following the end of slavery, while white women were looking at birth control as an emblem of their reproductive freedoms from motherhood and gender types, it was also used to point to the unfitness of Black women to give birth to healthy, intelligent babies void of dysfunctional personality traits, which held Black women as lacking capability to add quality offspring to society that wouldn't be a burden. Therefore, understand, while slave owners sought to force Black women to bear children, policies during the 1970s sought to reduce Black women's fertility. Let's move further along Black maternal health to the 1990s. During this period, reproduction became a criminal offense. On February 2nd, 1992, A 28-year-old Black woman gave birth to a healthy baby boy in South Carolina. The hospital staff determined that the baby had traces of cocaine in the baby's urine, and they notified child welfare authorities. 2 months later, the mother was arrested for endangering the life of her unborn child by smoking crack while pregnant. The attorney had encouraged the mother to plead guilty to child neglect charges. The attorney was a prosecutor and had prosecuted many pregnant addicts, so she did not think to challenge the application of the child neglect statute to a fetus or the constitutionality of the charges brought against her client. Typically, the women would be placed on probation and required to get drug treatment. However, in this case, the judge asked at the start of the trial, "Is this a crack baby?" He said to the mother, "Why would you not just take a pistol and put it in your mouth and blow your head off?" The attorney tried to explain that her client had since been in counseling and the baby was doing well and she had stayed off drugs. She tried to advocate for the client and advised the judge that her client wanted to be placed in residential treatment facility as had been the previous practice. The judge wasn't interested and instead said, "I think I'll just let her go to jail." He sentenced her to 8 years in prison. Between 1985 and 1995, at least 200 women in 30 states were charged with maternal drug use. 82% of Americans polled in 1989 agreed that a pregnant woman who uses crack cocaine and addicts her unborn child should be put in jail for child abuse. Therefore, they needed the maternal medical community to test and report women, mostly poor and mostly Black, who were struggling with addictions to child protection. Women with addictions were not safe or protected when they delivered in hospitals. They knew they would be criminalized and not shown compassion and connected with the resources to address their addictions. On August 22nd, 1996, President Bill Clinton signed into law welfare reform that ended the New Deal federal guarantee of cash assistance for American children living in poverty. The new law gave states increased authority to AFDC, which is Aid to Families with Dependent Children. It established a lifetime limit of 5 years for payments to any family and required families to find a job within 2 years. He pledged to end welfare as we know it, and he did. Policies that discouraged women on welfare from having children were justified by myths about the connection between family structure, welfare, race, and poverty. These myths included that the promise of welfare induces childbirth, that welfare dependency includes poverty, and that marriage can solve the problems of children in poverty. There are many other examples of which policies were used to subjugate Black women's autonomy around birth justice. However, because of time, I'm not able to share them, but the point is that Black women have endured many injustices that have created a distrust between them and the medical community. Removing their voices and their experiences from the table only furthers to exclude them from the right that all women want for themselves, to be treated with respect and dignity when engaging with maternal health providers. Stories that we have heard are all too common across this country and in this state about Black women's experiences giving birth. The NAACP, as a trusted member of the Black community, wants to make this survey available to be a bridge for the women to share their experience to the medical community and for the medical community to hear them and respond with changes to the quality of care provided in doctors' offices and hospitals. Dr. Deidre Cooper-Owens and Dr. Charla Fett asked questions in 2019 that still remain unanswered today. And this survey is one means by which we want to fill the gap created when these questions are ignored. The questions are, how does the medical profession unlearn a pattern of dismissing Black women's self-reported pain when that pattern is rooted in centuries-old beliefs? 2, how does a community learn to trust doctors whose forefathers were interested only in repairing and restoring Black women's reproductive health so that slavery could be perpetrated? And 3, how can doctors learn to be more sensitive to the concerns, both personal and cultural, of Black women who still hold stories and memories about forced sterilizations, examinations, and procedures on their family members, friends, and community? The Maternal Health Survey is one cog on the wheel toward birthing justice for all women, especially women of color. Observation of Black women's reproductive decisions has been a central aspect of racial oppression in America. The control of Black women's reproduction has shaped the meaning of reproductive liberty in America. Language of healing to Black women in the USA is large and is varied. But we want you to support the Maternal Experience Survey, share it with your clients and colleagues, because we believe hearing Black women's voices is one way to change the experiences, the quality of care that they receive in this country. Thank you.
Cheryl, thank you for that very sobering historical perspective of Black maternal health in the US. Now we'll hear from Tatiana, who is a doula from the Sister to Sister Community Doula of Essex County. It's important for us to note that the doulas are one of the central solutions under the Nurture New Jersey plan to support and protect women during birth in New Jersey. Tatiana, please share your thoughts about the doula and how they support Black women in New Jersey. Thank you.
Sure. Thank you for having me. Again, my name is Tatiana Smith. I am a community doula. I have been a doula for 4 years. I just want to start by saying, first, Cheryl, thank you so much for that brief overview. There's so much more to discuss on that, but I encourage everyone on this call, if you can, read Killing the Black Body by Dorothy Roberts. She really gets into all of the policies that have been shaped around Black women's reproductive justice. It's a really introspective book, and it will really change the way you see how policies are made in the United States. So definitely encourage the reading of that. In particular, this false equivalency towards Black women having more babies to encourage welfare, that's kind of been like a sticking point in a lot of policy making. When we know the data shows that women having babies is not, it does not encourage welfare. It's actually a symptom of poverty. So this is one of the many things that Roberts talks about in the book. So again, I encourage you to read that. I want to talk about what the difference is in a doula and what a community doula is. So a doula is someone who provides emotional support for birthing families, not necessarily birthing families. So there are many types of doulas, but for this discussion, we're talking about birth doulas. So we provide support before labor, during labor, and after, shortly after, to not only the birthing person, but the surrounding support family. So we stay with families throughout the entire labor. So whereas a family medical provider will come in and out or change shifts throughout a labor, we're there from the beginning of active labor all the way, and we never leave. We never ever leave. It's really critical that the support person, the doula, is there, and that the person, the birthing person, has that person to rely on as an emotional support. Now, the difference between a doula and a community doula is that we, community doulas, we are people that serve people in our communities. So we look like the people that we're serving, but also on a bigger level, we are serving people that may have other barriers that may cause a difficult labor or a difficult family situation. And so we're stepping into quite difficult situations at times that a regular doula may not have to deal with. There may be issues of financial issues. There may be issues of domestic violence, not enough family support at all. And so we are taking that extra step, and being someone who looks like them, we're offering that additional emotional support. We know historically that Black women, they are not as supported. They are not as listened to in a medical setting. And so what we do is we provide contextual, culturally relevant information and resources for Black and Brown birthing people. So whereas if a person goes to their medical provider and they give them the standard medical advice, we're not necessarily giving it medical advice, but we're telling them where they can find culturally relevant materials that speak to them and can help them make the best decisions for themselves. So one thing to note, and I always note to everyone, doulas are not medical providers. We don't do medical procedures. We offer emotional support, and also during the labor, we offer comfort measures. The other essential thing about community doulas is that we don't operate individually. We operate as a community of doulas and support sisters. And so we're not going into situations by ourselves. We have a team that we work together, and we build off of the knowledge of each other, and we share knowledge. So I work in the private field and I work as a community doula, and I see the stark differences. I know that as a community doula, I'm able to pull on my doula sisters and get culturally relevant resources that are going to speak to our clients a little bit differently than the clients that I might have on the private side. So some differences, some really important values of a doula in the medical setting. We help parents advocate for themselves. A lot of times what I've seen in my experience is that Black women are ignored when they bring up issues of pain or issues of their past births. Their concerns are ignored, or they're told that, this is normal. And we try to reiterate to the clients that they should always let their medical provider know when there's an issue. So I think one of my biggest, my happiest moments as a community doula was working with a mom who she had gone through several different providers because she had a C-section. So a lot of our moms do endure C-sections, but they do desire a vaginal birth. So this particular mom, she had 2 C-sections. So the prognosis for her having a vaginal birth was very low, and she was denied that with 2 doctors and a set of midwives. They declined to support her in her labor. So we did help her find a doctor who did support her. And it was a long labor, but all in all, at the end of it, she was able to have a vaginal birth. So it's very rare to have a VBAC after 2 C-sections. After 1 C-section, a lot of doctors are already saying no, but after 2, it's absolutely not. So to find a doctor that was able to give her the space to labor, and also a Black doctor that was respectful of her and her needs and her desires, and able to just really listen to what she needed and what her family needed. She was able to have a really positive birth experience. So when we witness that as doulas, that is the heart of what we are trying to do. We want to help give Black women voices, Black birthing people voices in the medical setting. One of my least positive experiences was with a Black same-sex couple. So we we've come a long way in America as far as medical providers offering support to same-sex couples, but we're seeing with Black couples that it's not the same. They're not given the same respect. And so in here, there's that divide with the LGBTQ plus community where Black people are not getting the same equity as their white counterparts. And so again, we have to help them advocate for themselves. And in this particular situation, the partner of the laboring person, she was flat out being ignored by the midwives. They felt that because she wasn't the married partner and she wasn't a male, they didn't give her the same agency and the same respect as they would a heterosexual couple and a white couple. And she really felt that she would ask questions and she would be flat out ignored in the labor. At one point, it became a point of contention between her and the medical provider, which provided more stress to the laboring person. And we see that a lot of times where there's so much tension between the laboring, the partners and the medical providers, that it causes undue stress to the person that's actually laboring. So in this experience, I was able to stay with them for the whole labor, and she really, the partner really appreciated me being there, coaching them through it, calming her, and just making sure that her emotional needs were met. When the partner's emotional needs are met, they're able to further support their laboring partners. And I think that's also critical. Paying attention to everyone in the room, not just the laboring person, because these are the people that laboring person, that they're part of their lives. So, that was a negative experience that ended positively. The baby was healthy, the family is happy, and I still talk to them. But I'm really grateful for this survey. I hope that, as many birthing people are able to participate and give valuable feedback that will help change some of these outcomes. So thank you.
Thank you, Tatiana. That was an important set of data points that we can totally use. And just imagine being able to aggregate that information in a survey like the experience survey that would help shape some of the outcomes for moms and communities. Thank you. Next, we'd like to bring on Constance Days Chapman, who is from the NAACP BIMM task force, the chairperson of that task force, and helped to spearhead this whole effort. We'd love to hear from you, and then we will bring in Sharal and Melissa Fox from Ascenda Health to talk about the actual survey. Thank you.
Good morning. It is a pleasure to be here with you. My name is Constance Days Chapman, and I am the NAACP Atlantic City Branch's Black Infant and Maternity Mortality Task Force Chair. It has been such an honor to work on the task force amongst so many other individuals that share such passion and commitment to advancing our community. During our first few meetings in 2019, the task force began brainstorming ideas surrounding the goals and the focus of the task force. We asked ourselves, what do we really want to achieve? We explored the history surrounding infant and maternal mortality, and we assessed the needs of our community. We decided that 2 products would be the result and the focus of our task force: the Maternal Experience Survey and the Black Infant and Maternal Mortality Toolkit. The members of the task force believed that the survey was important because it's a direct way to address the health disparity that results in preventable deaths by empowering mothers of color to share their prenatal, their birth, and their delivery experiences in order to improve overall health care and delivery for women of color. In addition to that, many of us on the task force had also had our own personal experiences during childbirth that, like so many others, could have possibly been prevented had someone listened, had some other resource been made available, had we received better or proper care. So that we can accomplish both tasks in a timely manner, we decided to create subcommittees to work on each project. Cheryl Hackett and Melissa Fox were appointed to work on a maternal experience survey, in which they did an exceptional job. They developed the questions and they kept the task force updated on the progress. And at each meeting, the task force provided comments, suggestions, and revision requests. After the final product was complete, the survey was given to a focus group of women in Atlantic County and Essex County. It was a very humbling experience that reaffirmed the importance and the power of our survey. I am so proud of our Maternal Experience Survey and very grateful to Cheryl, Melissa, and the members of the task force for their hard work and their dedication. I would also like to give a special thank you to First Lady Tammy Murphy and her great efforts also. I look forward to the impact and the outcome that this survey will have in the future. Thank you.
Thank you, Constance, for that introduction. And now to the heart of the survey and hearing about the survey, we'll bring back on Cheryl and Melissa Fox. Thank you.
Thank you again. And thank you, Mandy, for giving us that view of how we got to this point. When Melissa and I were assigned to be the subcommittee for the Maternal Experience Survey, we got to work right away, and we thought about how important it was. What were the different questions that we wanted to have answered? We thought about the various stages of a woman's pregnancy and what questions would be critical at each of those stages. And we came up with a lot of questions and we had fun doing it, which was wonderful. But I'm gonna let Melissa take it from here and just really take you through the Maternal Experience Survey. If you haven't seen it already, just so you can get an understanding of how we thought this thing through, the sweat and tears we poured into it. Go ahead, Melissa.
Thank you so much, Cheryl. And this is such an important conversation that we're having on many different levels. And like Cheryl said, the way that we approached this was with hearts filled with love and commitment and a full understanding. We reminded ourselves every time we talked about it, why we were doing it and why this was so important. And the experience of Black women that you hear that's rooted in the context of what Cheryl shared earlier, that has led us to this point. And so where we are right now, we're in a powerful time in our country and in our state. And there are very few people who can say that they're not aware of the issue. They're not aware of why the issue exists. So the only thing to do now is to make the decision, where do I stand with how we move forward? What should I do in terms of taking action and eradicating and making a change so that these women and these children no longer have to die, no longer have to suffer, and these families don't have to bear the grief and burden of these losses due to childbirth. This should be a beautiful time. So we approached this with a very sobering heart, a very sober heart, very sober minds, and really understood how much is at stake. And so we're going to share this with you today, and I'm hoping that as we walk through this, you grasp not just the enormity of what we're doing, but the importance of your role and making sure that everyone in the community has as much access as possible. Because when we're talking about a survey, this is not just a survey. This is a tool. In some cases, it may be a weapon. In some cases, it may be an educational portal. But whatever it is, it's something that will give voice to sometimes the voiceless, and that will give a picture and a true accounting of what women are experiencing so that we have a proactive approach as opposed to reacting when the grief sets in and when we have the losses occur. So what I'm going to ask right now is if we go ahead and tee up the actual PowerPoint, and I'll walk you through what these slides include or what this will include. So it's really important to understand that the survey is meant to be very easy to use, but it is intended to be meaty. So as Cheryl mentioned at the very beginning, there were all these questions that we aggregated, all of these things that we knew if we were sitting in that seat, and if we had the opportunity to talk to these women, or these women had the opportunity to ask these questions themselves, what did they want to know? And what would change the system? What would really drive the conversation? And there were a lot of questions, obviously. So we did have to whittle that down to, what would be a portable and easily completable way for these women to respond. And then after we whittled it down, we took it back to the task force. We took it to two forums. We had two forums where we had women from the community come in and even further inform it. And from those conversations, we were able to create what you will see here today. So there were many steps that were put into that process, lots and lots of hours. We have had a couple of members of Cheryl's team, Carrie and Patricia, who were instrumental in bringing this forth. So it's meant to be very convenient and easy to use and very comprehensive. Women can come in at two points. If they're already pregnant or about to give birth or have recently given birth. So they're able to start the survey, start one version of the survey, and I'll show you what that looks like when we get towards the end. Go ahead and complete it, but then they can come back and complete it at another stage, or they can just complete one, but it will still give us an understanding of their experience. So if we can go to the next slide. So it is meant to be focused on the mom. So there's information that we're going to capture, which makes sense, so we can understand who we're talking to, who's coming to the survey. This is extremely important because if we're going to make true change, then we need to know who we're talking to. These women need to be represented as much as possible in terms of their individual information without having to provide their personal information if they choose not to. We need to get as close as we can to who these women are so that we can get a true picture of what needs to be done and even some trends that we may see. If we see women within certain age brackets that are being affected more than others, we need to understand that. We need to really dig into who we're talking to. Though the survey does collect, and you see here, multiple races, we know that we're focused primarily on women of color, especially Black women, because we know that they're the ones who are dying. And you heard the First Lady say it at the very beginning, at exponential rates, and those infants are dying at exponential rates compared to everyone else. So that is truly our focus, but we do want to, capture if there's other information in terms of how women identify themselves as a part of the survey. Next slide, please. So there are critical data points that we're going to be capturing as we go through, and this is just an example. So this is by no means the entire survey that you're seeing. It's meant to truly just give you a flavor of how easy it is to use. We're going to have it, it's going to be available via laptop, via smartphone. So it is very simple for people to use, very clean. So we're getting the dates of births, or was this their first pregnancy? And we also do ask the question, how did that most recent pregnancy end, if this is the survey that they're completing? We want to truly understand if it ended in the child dying, if it ended in the health of the child coming forth. We still want to understand those experiences because there were a series of events that led to that. And so we want to make sure that we capture that as much as possible, those very critical data points. Next slide, please. So as I mentioned earlier, the survey is set up into, and I think Cheryl touched on it as well, the different phases of the childbirth experience. So we capture as much as we can about prenatal care. We have seen the statistics that there are many women within the Black community who are not accessing prenatal care the way that they need to. So we want to understand why that is, especially if we understand that the statistics and the disparities that we're seeing cut across socioeconomic levels. So sometimes it's a result of access, but there's some systemic issues that the First Lady spoke to earlier. We want to understand what's going on. So we're asking them, where did you receive it? How did you pay for it? And there's some other questions around how were you received? What was what was your overall experience? And if you notice the question here in the bottom right-hand corner of the third block, do you think how you paid for your care negatively influenced how you were treated? That gets to the heart of why this survey is so important. There's the quantitative data, the hard facts that we're capturing, absolutely. But we also want to capture how they felt. What was your experience when you walked in? Tatiana spoke to it earlier. There are some things that are difficult to capture and that you can point to and say, well, this is exactly what happened, but they can tell you how they felt. People can tell you what the experience was that made them not want to return. So this survey aims to capture that as well. Next slide, please. So as I mentioned, it's important for us to get the perspective of the patient. So when you look at these questions that we ask, and there are very few surveys that go across the care continuum, and that's why the MES is so important. It goes across the care continuum that really gets to how did you feel? What was your experience? If you look at this first block here, it says, when you think about how the front desk staff treated you when you went there, please choose yes or no for each statement. Treating me with respect. Yes. Respect is subjective, but that is powerful because if you don't feel like your voice is being heard when you go to that office, there are chances that you will not return. Or there may be some barriers that you receive down the line that could have been informed by the fact that your initial experience was a negative one. So throughout the survey, we ask those types of questions, and we are actually able to track their experiences back to a single provider if necessary. Now, the providers, this is meant to be helpful to them, because I am sure that every healthcare provider as an entity is interested in making sure that their patients are well cared for. So if there is a weak link in the chain, then the assumption is that they will want to know that. So we will make sure that this information is provided and any trends that are identified are clear. Next slide, please. So we are really looking to get the honest feedback from them. So this goes again into what we spoke to. If you raised concerns, did anyone hear you? Did you get the supports that you needed? If you said that you were in pain, did you get the pain medication and support that you required? If you said that you were thinking that you weren't being heard, what was the response to that? What was the negative impact? So we look to capture all of that through this survey. Next slide, please. We also provide women with the opportunity to tell their stories in their own words. So though it's meant to be very, very succinct in terms of how most of the questions are set up, and that's feedback that we got directly from the forums that we had, we also want to give them the opportunity to tell their story. And so they are able to put in their own narrative. If it was a positive experience, they can do that. If it was a negative experience, they could do that. But we give them their own voice. You will hear that. You've heard that many a times on this call today. And I will say it again, that the voices and the empowerment of the women behind them and the families behind them, they are important. So giving them a place to express their voices was important through this entire process. Next slide, please. So the other part, of course, we want to hear, and there's some different questions, but the same type of approach as with the prenatal for the labor and delivery phase. So, we want to understand where they delivered. Did they include your support person? And this goes to the conversation about doulas. They're important advocates in the birthing process. So if the woman has them as a part or their partner or whomever, did the provider allow this person to be included in discussions about their labor and delivery? This is very important because if there's an additional advocate to help to further the concerns, raise the alarms if need be, then we hope that many of these cases of grief and loss could be avoided. So having another voice there that's empowering you and supporting you is extremely important. We want to know if that's being allowed. And again, here, if you raise concerns during this phase, were they addressed? Next slide, please. And these are just some other examples of the really critical questions that this cross continuum gets to. The one on the left is extremely important. Did you feel uncomfortable asking questions or discussing your concerns? Did you feel uncomfortable sharing your voice and using your voice and feeling empowered about advocating for yourself? We want to know that. And if so, then we need to identify those trends and then give that feedback as necessary. And then the ones on the right really just allow them to, free form in terms of what you felt. What were all the things that you felt? If they were positive, powerful, respected, supported, wonderful. But afraid, confused, dismissed, we want to know those as well. Next slide, please. And we also want to know, how was it after the birth? What happened then? When you were discharged, did they get the supports that they need? Did someone follow up with you in a timely manner? If you were having complications, did you hear from someone quickly to be able to address those concerns? Were you brought into the doctor's office if needed? So we do drill down into that level of support. And I'm hoping that all of you are really grasping how powerful this is in terms of going across their entire experience. That is the really critical full picture data that we need to make an impact. Next slide, please. And their postpartum care experience as well. So some of the same types of approaches, same types of questions, but as I said at the very beginning, extremely comprehensive in terms of the information that we're looking to capture. This is important, and we'll get into a little bit why on a county by county basis, this is going to be critical as well. Next slide. So as I said, this is meant to empower, this is meant to provide voices for those who have not been able to do that in a consistent and meaningful way in the past. And most importantly, it's at a population health view. Let's look at those trends. What is that we're seeing that's consistent across this county? What are we seeing in terms of need and focus and where we should direct our resources, where we should direct our time, where we should direct our advocacy, and where we should direct our funding. So this is very important and will give that full picture view. Now, the other thing too, when we're talking about empowering, we're not looking just to co-opt these women's voices for, you know, generic purposes. We want them to let us know, where are we allowed to share your information? And we do that here on the right, you see here. Please check as many boxes below. Where are you comfortable with our sharing your stories, especially if they're putting in their own unique narrative, their own unique voice? So we want to be sure that they feel okay with that as well. Or if they don't want to give us permission to share it outside of the survey, then we will not do that. And we have mechanisms in place to control that. So next slide, I think this is probably the last one, and I'm going to tee up the, oh, sorry. So just one thing, just to let you know, when you need to access the survey, this is where you go. And I believe that the address is being put into the chat. So if you want to see what the survey looks like, the different versions of the survey, go to njpreterm.org. You'll be able to take a look at it without even completing it initially. If you want to just get a feel for it, you see that it's available in a couple of different languages here. And you also see what I mentioned earlier. There are two different ways that women can enter. The first, on the green, on the right side, I'm currently pregnant, or I recently gave birth. So they can choose their entry point to be able to provide the information that's needed for the survey. So this is a wonderfully comprehensive, easy to access, beautifully presented survey that is really built on the voices of the women who we heard from the community. Now, and we can start to tee up the next document. What now is, you know, a lot of you may be thinking is, then how do I get involved? You know, what is a way that I can start to think about how to use this essential tool for my county? So, you know, as Cheryl and I and other members of the task force were talking about, you know, how do we do this in a very coordinated manner? What we want to do is to make sure that as we roll this out across other counties in the state, that we're doing it in a consistent and in a cohesive manner. The reason is because we want to make sure that the data that we're capturing is consistent, number one, but we also want to make sure that the way that we're presenting and messaging to the women in our community is consistent. Why is that important? That's important because the power is going to come behind that message. The power of a singular message, of a consistent message, is what is going to allow us to be able to help the mothers in our community and also help to make the changes that are needed in the larger healthcare community, so we aren't having this exact same conversation 2, 3, 4 years from now. So if we are going to move it forward, we needed to create tools that the counties would be able to use and be more consistent and feel supported at a county level. So what we created was this county launch packet. Next slide, please. So everyone, counties who are interested in bringing the MES to their county will receive this packet. And this packet will walk them through what's required, what's best practices, and what we've learned thus far for Atlantic County in terms of the best way to launch the MES. So they'll get this information, and it shows here what is the purpose of it, just to remind everyone, again, keep us on the same page with the single message. Next slide, please. And then the steps that are required for a county launch. So again, this is at a very high level. The county MES lead, whoever that may be, and I'll get to that in a moment, will assemble the proper committee. The committee will then schedule a launch meeting with the state MES advisory group, which includes Cheryl, myself, and a couple of other members of the task force. So they will feel fully supported with this. They will feel fully engaged and fully connected to the larger mission. Then we'll work together to make sure that the meeting schedule and the key roles are identified, and then start to implement a strategy based on a template that we will provide. Next slide, please. So this is the recommended participant mix for the committee memberships. So if your county, this is something that you will have, if your county is interested, you can then look at this and then start to identify who do you need to engage from these different areas. So the recommendation, of course, similar to Atlantic County, is that the lead group should be the NAACP or a similar organization. So then those other square or blocks that you see here are the other areas that really should be represented to make sure that you have maximum engagement and that you have maximum impact. So if there's some switches that need to be made, that's totally up to the county, but this is the way that we found we've gotten the most feedback and traction. Next slide, please. So when that first launch meeting happens as part of the packet, this is what we'll touch on. Now, there will, of course, be more detail, but when we, as the state MES committee, will meet with the counties, these are the things that we're going to address: the purpose, the messaging and strategy, and we'll take questions about that and work through whatever nuances that may be needed for the county, the outreach and marketing plan, and then the next steps. And we'll help to lay that out for them. There will also be support meetings at a state level, and that's the state MES committee, as we're referring to ourselves at this point, to make sure that data is provided and support is provided on an ongoing basis. Next slide. This is a sample of the template that will be part of their launch packet that will be provided. And as you can see, we're being as detailed as possible. So if they're looking to launch, when they're looking to launch and implement, what are the different steps that need to take place? And we are very specific between 0 to 7 days of launch, for instance. Add the link to the survey on key websites. That link will be provided to the county. So there won't be a whole lot that you have to do in terms of creating or designing, because that will be provided to you as a part of the initial packet. You'll just need to tweak it for your individual county. And then the other pieces here, it'll just be launching according to that timeline. Again, just best practices that we found thus far for Atlantic County. Next slide. And so this is the last thing that you would see as part of this launch packet. You know, just the participation is important. Commitment is important. So having your own monthly CMESC meetings, and so that's at the county level. And then we'll be having the quarterly statewide meetings with Cheryl, myself, and some other members of the task force. And then you'll also be receiving regular results reporting. So, and so you can take this down now. Thank you. So that is, you know, in a nutshell, the packet that counties will receive if they are looking to be involved. And we hope that many of you are. I think Cheryl's going to speak to, you know, who's kind of in the pipeline right now and how we're proceeding with that. But we are very, very proud of the work that has been done thus far. And we're looking forward to using the MES as part of the larger state strategy to make the changes that are needed, so we don't keep having to deal with this horrible disparity that exists in the Black community. Cheryl, did you have anything else?
No, I think I'm gonna move on and let S6 share.
Thank you.
Melissa and Cheryl, that was amazing. Thank you for walking us through that roadmap. And now we're going to hear from the next county that's up. It's Essex County, and we're going to hear from Cherise and from Levita and how they're organizing Essex to do the MES.
Good morning, everyone participating on today's panel. My name is Cherise Dawson. I am the Health Committee co-chair at the Newark NAACP branch. I'm joined today with my co-chair, our second vice president, with Levita E. Johnson. Before I begin, I'd just like to thank ACNJ, Cheryl Hackett, the Atlantic City chapter of the NAACP, our partners over at Partnership for Maternal and Child Health of Northern New Jersey, as well as the Prematurity Prevention Initiative for bringing us into this, and we're so happy to be a part of it. To give some more information on how we in Essex, first, why we want to do this, the very first reason is Essex County happens to have the second most live births in the state of New Jersey. That's as per data collected in 2019. And we also, unfortunately, have the highest infant mortality rate in the state between 2016 and 2018. So this is a significant issue, and we're all very passionate about it at the Newark branch NAACP. So we were actually contacted by the Prematurity the Partnership for Maternal and Child Health of Northern New Jersey, as well as the Prematurity Prevention Initiative. They reached out to our chapter in January of 2020, right before the world changed, as far as we knew, to discuss collaborating on this issue and how we could do something actionable on it. And that determination came down to what we were doing. We created a forum, a 3-day forum in reference to addressing this issue, these very, very important issues. And we made sure we had participation, not just from our local birthing hospitals such as University Hospital and Newark Beth Israel, but we also had representation elsewhere. My co-chair will go more into detail about that. So we wanted to continue the work that was done in Atlantic City with their work with the Maternal Experience Survey. It is a brilliant project, and we believe that it's really a way for us to get concrete information on how to approach this and adjust this issue to create equity in healthcare. And and we're looking forward to starting it here. We already have a list of approximately 20 partners that are interested in joining the Essex County equivalent to the Atlantic County Maternal Experience Board. It is the numbers that make up, or the persons that make it up, are not just medical professionals. It is community advocacy groups such as our own, as well as those who provide maternal education within our communities, doula organizations, and they're all very interested in beginning this process and beginning to implement this survey. So we're really encouraged by that. So at this time, I'd like to hand it over to my second VP and my health co-chair, Lavita E. Johnson, to talk more about the virtual event we held in November of 2020.
Well, good morning, and thank you, Sharice Dawson. Thank you to the committee that has put this together. And again, to First Lady Murphy, it's been a pleasure and an honor to continue on this journey. So back in November 2020, we, the Black Infant and Maternal Mortality Coalition for Essex County, we hosted this virtual event on Zoom. It was streamed on Facebook, and it was entitled, "Why Are Black Mothers and Babies Dying?" It was a 3-part series, 2 hours each. The first was held on November 9th, entitled, "Why Is This Important?" The second was on November 16th, "Who's Affected?" And November 3rd, "Where Do We Go From Here?" It was done in collaboration with the Prematurity Prevention Initiative, the Partnership for Maternal and Child Health of New Jersey, University Hospital, Newark Beth Israel Medical Center, the City of Newark. And from there, the speakers were comprised of community organizations, advocacy groups, clinicians, and parents who lived and dealt with this experience firsthand. We also, again, had First Lady Tammy Murphy, First Lady Linda Baraka, and many, many more, which also included the president and CEO of University Hospital, Dr. Sharif El-Nahal. In total, there was 234 participants via Zoom, and within the month, it recorded a series and had a total reach of 11,035 individuals, 4,600 views streamed on Facebook. Most women were between the ages of 25 and 34, right here in New Jersey, which are 79% affected. While others were from New York at 13%, Delaware at 1.3%, and Pennsylvania at 1.3%. And as a result of this series, preliminary steps were identified to implement change at the community level and to increase advocacy about the Black infant and maternal mortality. We also plan to host an additional event on this year, prayerfully in September of 2021. The next steps were implementing the Maternal Experience Survey here in Essex County. We will be creating a county maternal experience survey as well. It would be comprised of NAACP, Newark, New Jersey, and the Essex County chapters, elected officials, residents of Essex County, grassroots organizations, hospitals, and maternal health organizations. An email invitation will be sent out to potential members. And this advisory board will be limited in number to plan the launch of the survey. And we will virtually launch the survey on Zoom and invite those to watch in Essex County and throughout the world to participate and attend. Because this is going to be another historical event to mimic what was done with our sister branch in Atlantic County. The survey will be accessed via the Prematurity Prevention Initiative website at njpreterm.org for all counties. And you can contact Sharice and I at the North New Jersey branch at health.northnaacp@gmail.com. And we look forward to being able to launch the Maternal Experience Survey, and we will see you in virtual attendance. Thank you and have a great day to you all.
Thank you, Levita. Thank you, Sharice, for bringing us up to speed with what's going on in Essex County. I'm here now. We're going to go in quickly into the question and answer period. We don't have a whole lot of time, but we'll take a few. I'm here with my co-chair, Natasha Dravid from the Camden Coalition, who is the co-chair of the Maternal Infant Health Committee for Pritzker. Natasha, do you want to go through some of the questions and we'll bring them to the panelists?
Sure, and I'd like to invite all of our speakers to come back on camera so we can field some of these questions. We have a couple of questions, and I know Tatiana had to drop off, so I'm wondering if any of the other panelists could speak to programming that is being developed to increase the number of doulas of color that are connected specifically to the communities of color or underserved populations. I know there are some initiatives coming out of the Department of Health to continue supporting doula programming across the state. I think there are different, Tatiana spoke about the different community collaboratives, and there are several of those across the state, and there are efforts going on right now to continue to support those collaboratives and continue scaling the important work of doulas across the state. Melissa, do you have something to add to that?
Yeah, I was just going to add, for ACNJ, we have begun training our nurse staff and some of our community staff to become doulas. So we're extremely excited about that. And then there's some potential partnerships that are coming up where we're working within Atlantic County to help to expand that, working very closely with Dr. Washington. So those are the things that I am aware of, definitely within ACNJ, and then what we're doing with Dr. Washington, but I'm sure that there's many other things around the state.
I have a question. I don't know. I think most of the questions, Natasha, were around the doulas, right? And since we don't have Tatiana here, I think I'd like to move on to the questions specifically about the roadmap for the MES. Cheryl, I have a question. So you have Essex County, what other counties have signed on so that we could let people know, to start queuing up?
Well, initially, the Prematurity Prevention Initiative grant was funded for Atlantic and Essex County, which is why they were the initial counties, and Essex will probably be launching within the next 30 to 60 days. So right now, women who are from Essex can access the survey and complete the survey, but we will have a form, as Levita already mentioned, we will have a formal launch in Essex County. The same is also for Camden, will be following soon after Essex. But right now, women in Camden can now go on and assess it, but we want to have a formal launch in each county as it goes. What we're really doing, because when you look at Newark County, they cover a lot of the areas where there's issues with Black infant and maternal mortality. So getting them on as when we do is critical, as really being one of the counties that really needs a lot of attention around this. And so we're glad that is the next one. Like Levita went through what they've already started. I've been working with them. They were ready to go, and I was having to slow them down because they're ready, to get things going. But we want to make sure everything is done in a way that it can launch very successfully. And what we will then do is look at the counties as pretty much as they rank, or the counties that seem to have the most energy and excitement, like we're ready to go, they can reach us, and then we will begin to work with them as it goes. And we do one of the things that Melissa kind of mentioned is if in a certain area the NAACP is not present or not a strong present, then it is important that other critical organizations that represent the Black and Brown community step forward and be that lead agency as we work through it.
You know, one of the things that you'd mentioned in the past is that although the focus is on Black and Brown women, any woman can complete the survey.
Absolutely. When we started this out, as was shared with Colleen and Constant, we were focused on Black women. And it was always a question we were constantly asking ourselves over and over throughout that process, what about other women? But we know that right now, when we look at the stats, like what the First Lady shared, a Black woman 7 times more likely to die, we felt that's where the attention needed to go. However, we recognize that white women die from pregnancy-related complication, Asian women die from it. It is not just Black women. And so therefore, we want all women's experiences. We will welcome those experiences because they need to be heard too. But initially, this was set up with that focus of getting the voices of Black women heard.
Can I ask a question as well to Cheryl and Melissa? I think you've done such an amazing job of kind of showing the survey as a tool for change. And I'm wondering about the vision and sort of the how you're thinking about this feedback process of using the data, activating the data, and really feeding back to hospitals and health systems. What do you see that looking like?
Yeah, we thought about that a lot. And one of the things we have to put out there and let everyone know, just because the NAACP is involved does not mean the plan is to be adversarial in any capacity. Right. The plan is to work in collaboration with hospitals and birthing facilities to take these experiences to inform the care, you know, to inform if there's implicit bias showing up in an interaction. To inform if there are inequities based on how a person is treated, like Tatiana shared about the same-sex couple, right? So it is not to be used in that way. That is not the goal. Our goal is to get the information and then share that information as needed. The other thing is to make sure that we can use it as a way to just keep our finger on the pulse of change happening, and use it as a guide. So we will know that, hey, we may have a facility, maybe we get a couple of women that share it and didn't have a positive experience, but we may get women that come back and say, I went back again to that facility and this is how it's changed. And we want to share that too. So I don't know, Melissa, if you want to add anything to that, but that's how we were really looking at it as far as working with the community.
Yeah, I mean, I think you touched on it all. If I was to add anything, it would just be, you know, we are being very mindful about how we are disseminating the data and who has access to, for instance, the raw data. But I think what's more important is for people to understand the trends. And so that's the part where we will be very thoughtful about how we are making that available and at which points.
Yeah, I love that it is linked to hospitals or providers so that they can get the feedback directly. The other question that I had is, if a mom may have had a traumatic experience and may not want to share that traumatic experience right away just because of what it may bring up, what's the timeline for a mother who's experienced not such a good childbirthing experience to complete the survey?
Well, one of the things, we have not made it where if a woman gave birth a year ago, she cannot complete the survey. At any point a woman wants to complete the survey, she can. That's why we ask certain questions about, you know, the timeline, so we know if this was a baby that was born 2 years ago and now she's at a place to talk about that experience, or now she has the tool by which to share it. We want to know that we're sharing something that happened 2 years ago. That's the only fair thing to do if you're bringing it to a hospital system.
Yeah. And I think one person had a question about was the NAACP in Cumberland County contacted? I guess they're interested in bringing it to their community as well. And maybe the Cumberland County NAACP has to contact you.
We have not contacted Cumberland County. However, Cumberland County is on the radar. I mean, when it comes to some of these birth outcomes. I mean, if Cumberland County is interested, we definitely want them to participate. If you go to NJ preterm, right on that first page, at the top, I had them put a link that says, welcome maternal and child health professionals, sign up for updates. Because if you sign up for that, so you're in Cumberland County and you want to know when it's time, when we're coming there, that way we'll have your information as soon as it's like, okay, next up is Cumberland, you will be contacted to participate and be a part of that group that Melissa shared on that diagram that showed all of those organizations. You would be a part of that.
Excellent. Are there any other questions, Natasha?
I think those are the ones most related to the survey. So I think we have just a couple of minutes left. Patricia just dropped the link in the chat again for how to get involved, how to get more information, njpreterm.org. So thank you everybody so much for joining us today. This project is just such an incredible opportunity for us to move the ball forward in New Jersey. So thank you everybody.
Thank you. Cheryl, do you have any last words that you'd like to share? If not, we're going to wrap. And again, thank you everyone from the First Lady on down for participating in this and for bringing this forth.
Yeah, we're just really thankful for this opportunity to have collaborated on this event today at such a time as the Black Maternal Health Week. We think it's critical that Black women have, reproductive justice and birth justice, like all birthing women desire for themselves. So again, if you are interested in taking the Maternal Experience Survey, you can go to njpreterm.org, and there's a window that pops up. You can click on that and go to that page. We have it in English, we have it in Spanish. We've broken it out. So if you're currently pregnant and you want to complete it, you can do so. Or if you've already delivered and you want to complete it, you can do it that way as well. Or you can just complete it in full, doing your prenatal and postpartum. You also, like I just mentioned, if you're interested in being on that list for when we come to your county, please also fill that out as well. And I think that's it. We're just happy that you guys thought this was important enough, and we look forward to working across the state to see this happen.
Awesome. You have the last word. Thank you everyone for attending, and we will see you again soon. Bye-bye.